So let's resume with our talk of emergencies of hyperglycemia, namely DKA and HHS. Now, I hate to do this to you, but I got to. There are some formulas you need to know, and so you can pause it here and look at this if you want again. But let's go through these really quickly. The first one is the anion gap, and that is about a measure of how much acid is in the blood, metabolic acidosis, and that's the sodium minus the chloride minus the bicarbonate. And normal is around 10. It depends on your lab, so you should check what your lab does at your hospital. But 10 is a good number to think about. Normal is around 10, and if this number gets higher and higher, means you're wondering if there's an acidosis there. Now, the corrected sodium is something we need to think about. The sodium that you get from the lab is going to be artificially low, so you need to fix that. And so the way you fix it is by adding 1.6 for every 100 of the sugar that is above 100. So the way to write that mathematically is the glucose minus 100 over 100 times 1.6 to the sodium. So let's say the sugar was 300, so that's how many hundreds over 100 is it? Well, it's 2, right? Because you have 300 minus 100 is 200, and then 200 divided by 100 is 2, so 1.6 times 2 is 3.2, so you're going to add that to the sodium. So remember, the sodium is artificially low. The potassium is going to be artificially high, and so you have to correct for that with the pH, and so you're going to correct for it 0.6 per drop in pH by 0.1, or you could say 7.4 minus the pH times 10 times 0.6. You're going to subtract that from the K. So let's say the pH is 7.0. So 7.0 minus 7.4, this would be 0.4, right? And then 0.4 times 10, that's 40. And then 40 times 0.6 is 2.4. So you'll be subtracting 2.4 from the potassium. So that number that you get, it's actually lower. So you got to be very careful with the potassium, right? It's going to be artificially, it's going to come up looking higher than it actually is. So be warned about that. Osmoles, we're going to use this really in the HHS, so you want to know how to calculate that. The formula I had always been taught was 2 times the sodium, but I found another one that said 2 times the sodium plus the potassium, over plus glucose over 18 plus BUN over 2.8. And again, you're going to calculate the serum osmoles because you want to see how high those are. And then the total body water deficit you can see here is 1 minus 140 over the sodium times the weight in kilograms times 0.6. All right, so you don't necessarily have to memorize these, but know that these things exist. There are online calculators or calculators for smartphones that can help you calculate these numbers. But when you get your patient with HHS or DKA and the numbers look all wacky, the sodium looks strange and the potassium looks strange, you say, oh, wait a minute, I remember there was a way for me to recalculate those. And so here are the formulas for that. So now let's go over the rest of the stuff that we're going to see. So there's going to be some lab abnormalities we need to explain. And so the first thing is you're going to always see a white count that's elevated in these states. Just expect it. If it's over 25, this isn't a hard and fast rule, but worry about infections, and we know that infections are a common cause, a common trigger of DKA and HHS, so I would be looking for an infectious source regardless. However, if you got the DKA patient who says, yeah, I haven't taken my insulin in 2 weeks, and I've just been eating nothing but Snickers bars, well, maybe it's not infection, maybe it's the Snickers and lack of insulin, but just remember, you're going to see an elevated WBC. We already talked about the pseudo-hyponatremia that you're going to see on the labs, right? And so be careful for that, and you need to calculate it. Now, if you actually see a high sodium, then you know that we were expecting it to be low. If we see it high, it's extra high. And so you have big-time dehydration there. We know the potassium is going to be low. It's going to be higher than it is. So if it's low, you got to worry even more because the pH is going to say that it's actually much, much, much lower. And so remember, hypokalemia can cause some horrible dysrhythmias. So I'd be careful treating anything with insulin if the potassium's too low, because what does insulin do? It pushes potassium into the cells. So if you're giving insulin and the potassium's already low, it's going to drive more potassium in the cell, and now the potassium is going to drop even further, leading to possible dysrhythmias. So be careful with insulin in patients who have low potassium. So before giving the insulin, always check the potassium and wait. Give more potassium if you need to. Get the potassium above 3.33 before you even consider giving any insulin. We'll talk about that in a little bit. Other things that you might see are other lab values that are high, like the LDH, LFTs, creatine kinase, amylase, lipase, triglycerides as well. Obviously, in ABG, you're going to see that the pH is low. Now, what do you have to do in ABG, or can you do a VBG? I think the ADA says get an initial ABG, but most of us in practice are getting a VBG because the pH, you know what? It's close enough. It's within 0.02 to 0.03 of the arterial, the ABG. The VBG is very close. Even the bicarb is pretty darn close on the VBG. And so why put the patient through the risks of getting an ABG and the pain of getting the ABG when you can get a VBG? All right, the next thing we should talk about are IV fluids. Now, IV fluids are a mainstay of treatment in patients with DKA or HHS because we know that they're profoundly dehydrated. So this is going to fix their fluid deficit. It's going to dilute out the sugar. It's also going to dilute out those counter-regulatory hormones. And it's going to perfuse the kidneys so they can pee out all this other bad stuff. Now, the one time that this is different is in pediatric patients, and we'll talk about that in a second. And so what the ADA recommends is for the first hour, you want to give 15 to 20 milligrams per kilogram as a bolus of normal saline, and then you want to give 4 to 14 milligrams per kilogram an hour of half normal saline, unless, of course, the sodium is low, in which case then you can use normal saline. But remember, we said that the patients are going to have pseudo-hyponatremia, so the sodium is going to be much higher than it actually is, and so that's why they recommend possibly doing that. Okay, and so that's fluids. Insulin, we need to give them insulin, right? Insulin does lots of great things. It decreases the formation of new glucose. It decreases the ketone formation. It decreases lipolysis. And so you want to give insulin. Now, as we just talked about first, please check the potassium first. Because if the potassium is already starting out low and you give them insulin, you're going to push more potassium into the cells. And now you're going to get a profound hypokalemia and cardiac dysrhythmias, and your patient's going to code. So don't do that. So check the potassium before giving the insulin. And the common teaching was that you're going to use an IV drip. And you could start with a bolus, 0.1 units per kg bolus, and then you could give 0.1 units per kg per hour as a drip. Some people say don't give the bolus. I don't personally give the bolus. And you definitely want to skip this in kids. But this is one option, is to give a bolus, and another option is just to go with a drip. My worry is that it's going to drop too fast, and I'm not going to know what the sugars, be able to control it with this bolus. We actually use now something called Aspart, which is a subcutaneous injection. I don't know how it works, because I would think that the insulin depot that's sitting there underneath the skin would not be very well perfused, given that they're very, very hypotensive and dehydrated to begin with, but it actually does work. Now our goal is to decrease the sugar by about 50 to 75 every hour, and once you reach a sugar of less than 250, then you might want to decrease that that drip down from 0.1 to 0.05, so you drop it in half. And you may want to add some sugar to the fluids that they're getting. Now, remember, they still may have a bunch of ketones and that need to be cleared. They still might have a lot of acid that needs to be cleared. So you still need to give insulin despite the fact that the sugar is getting better because you want to clear those ketones. So you may want to keep giving the sugar until the bicarb is normal and the pH is normal and the ketones, you can't measure them anymore because they're gone. Now, another thing that we talked about, let's talk about some of the electrolytes again real quickly. We said for potassium, if your potassium is less than 3.3, do not give insulin, just give potassium, get that potassium up. In this middle range here, 3.3 to 5.3, you can give insulin, but also give a little bit of potassium because we don't want to reach that number down there. Above 5.3, we got a little bit of safety to work with, and so you can give just insulin without the potassium. Bicarb, should we give bicarb? This is somewhat controversial. Most people will say no, don't give the bicarb because it doesn't really help. But when they're profoundly acidotic, like less than 6.9, you might want to give some bicarb. Some will even say between 6.9 and 7 you might want to. Why? Because that low pH does lots of bad things. It's a negative inotrope. It causes altered mental status. It increases insulin resistance. So that bicarb may theoretically help something. Above 7, no benefit, so don't do it. I personally don't really give bicarb, but once you're in this zone here, you're really in dire straits, and so a Hail Mary pass might be to say, hey, let's just give some bicarb too and see what happens. Phosphate, you're only going to replace if it's low. Okay, so that's some of the treatment options. We got one more thing that we need to talk about, and that is something called cerebral edema. And so what happens mostly in kids is what we thought was too rapid treatment can cause the brain to swell, and then it could also cause them to herniate. This has also been seen in undertreatment of HHS too. And there are also some kids who come in with DKA with cerebral edema. So it's not necessarily that it's too rapid treatment. The thing is, we're not really sure what causes it. We do know what some of the risk factors are, though, right? If you have excess fluid, that might do it. If you have, what we're thinking is that the way this might work is you have a lot of fluid that's being given that kind of dilutes out the osmoles. You have an immature blood-brain barrier, and so now the fluid can get in there as well. And that causes rapid cerebral edema, which can then lead to herniation. Now, what is another problem? If you give that insulin bolus. Remember that insulin bolus I said I don't like to give? Why? Because it's going to drop the sugar really quickly. What happens then? The osmoles are going to drop really quickly. What does that mean? That means this fluid is not going to be kept in the bloodstream by the osmoles. It's going to leak into the brain again. And so you're going to have a problem with cerebral edema. If you do have cerebral edema, you might want to give mannitol and you might need to hyperventilate them. But in kids, be very, very, very careful. And so you want to be very judicious with the fluids. In fact, many places you have to consult the pediatric endocrinologist to treat DKA. Other places will have a pediatric DKA protocol you need to follow. Maybe we'll go over that in another video. But just remember, in kids, there's a danger of cerebral edema. Don't give a ton of fluids. Don't just bolus them super fast. It needs to be done slowly, judiciously. Don't just give them an insulin bolus either. That could also cause a problem. And so we think it might be overzealous treatment that causes cerebral edema. If you treat a kid like you would an adult, they might get this, but we're not quite sure that that's the case. All right, so that, my friends, is our discussion of the treatment of some of these hyperglycemias. Okay, I'm going to leave you here with this beautiful set of formulas. I'm sorry this one's long, it's about 15 minutes, but it's an important topic, and we did go over a lot. Okay, I will see you later.